Hello, we are Group 11, and our topic is Angina Pectoris, and in later slides, a simpler name angina will be used.
I'm Wan Hei Chun. Today I will talk about the introduction first. Angina is the heart disease characterized by chest pain or discomfort. Angina reduces the blood flow to the heart tissue. This affects the function of heart, affects its ability to pump blood, finally lead to heart attack or serious heart disease. Angina can affect people of all ages, but is most common in older elders and those with risk factors. Men are more likely to develop angina compared to women. Then I will share some statistics about angina. Approximately 10 million Americans are suffering from angina, which means 4% of elderly Americans having the angina. Then I will talk about the statistic of coronary heart disease. Is because the coronary heart disease have strong relationship with angina, and hence it can show the condition of angina in Hong Kong. In 1993 and 2011, we can see the death rate of coronary heart disease is increased. And in 2001 and in 2021, you can see the fluctuate in this period, which means there is low increase trend or low decrease trend in the death rate due to the coronary heart disease from 1981 to 2021. The whole period is decreasing. Then I will talk about the risk factor of angina. First, the age. The risk of angina increases with age, especially after age 45 in men and after menopause in women. Also having a family history of heart disease or angina can also increase the risk of developing the angina. The high blood pressure can also increase the risk of angina by increasing the workload on the heart. The high cholesterol, smoking, and diabetes can lead to the buildup of plaque in the arteries, which can narrow the arteries and increase the risk of angina. Also, sedentary lifestyle can increase the risk of developing angina. Also, the stress can increase the workload on the heart and increase the risk of angina. Also, some medications such as aspirin and NSAID can increase the risk of angina. Then I will talk about the common etiology. There is a lot of etiology cause angina, and I will talk about the most common one. First, the angina is mainly caused by the buildup of plaque in the coronary arteries. The coronary arteries are the blood vessels that supply oxygen-rich blood to the heart. The plaque build up in the coronary arteries. It can narrow or block the blood flow to the heart muscle, and hence it reducing the amount of oxygen that reach the heart. When the heart muscle does not receive enough oxygen, it can cause chest pain or discomfort, which is known as angina. Then I will pass the time to my groupmate Elvis, and he will talk about the pathophysiology mechanism.
Thank you, Jason. Now I will introduce the pathophysiological mechanisms of angina. The major cause is coronary atherosclerosis, which is distributed in one or more of the three major coronary arterial trunks. It has a high incidence in anterior descending branch of the left coronary. The second cause is superadded changes in coronary atherosclerosis, which involves the acute coronary syndromes caused by changes superimposed on a pre-existing fixed coronary atheromatosis plaque. And the third cause is non-atherosclerotic causes. Other coronary lesions, such as facial spasm, also cause angina. Let's talk about coronary atherosclerosis in more details. The triggering event is endothelial injury caused by hemodynamic stress from hypertension and chronic dyslipidemia. The second event is intimal smooth muscle cell proliferation caused by adherence, aggregation, and platelet release reaction, and also the infiltration of inflammatory cells. They release chemical mediators, resulting in the proliferation of intimal smooth muscle cell and the production of extracellular matrix. Monocytes in the blood also take a role. The LDL in the cytoplasm can cause the formation of foam cells and their death by apoptosis release lipid to form lipid core of the plaque. Another component is dyslipidemia, which initiates endothelial injury and dysfunction by causing increased permeability. A high LDL concentration promotes foam cells formation. Another event is thrombosis, because lesions are enlarged by attaching fibrin and cells. I have just talked about chronic atherosclerosis, and now let's move on to the superactive changes on chronic atherosclerosis. The first change is acute change in chronic atheromatosis plaque. The changes, like plaque hemorrhage, cause thrombosis and embolization of atheromatosis debris. The second change is coronary artery thrombosis. The first surface ulceration of plaque leads to partial or complete coronary thrombosis. The third change is local platelet aggregation and coronary artery spasm. Their aggregation on plaque can release the vasospasmic mediators, which are responsible for coronary vasospasm. And now Henry will talk more about the pathophysiology of angina.
Now let's turn our attention to the neurological pathway that leads to the pain sensation during angina pectoris. Unfortunately, with limited research from the scientific world, mechanisms that causes anginal pain and the neurotransmissions are still poorly understood. However, assumptions have been made to explain the underlying pain sensation. Firstly, during exertion, the oxygen demand of peripheral tissues and heart muscles increase. However, due to the formation of the plaque in the coronary arteries, blood flow towards the cardiac muscle is lowered. This also causes oxygen supply to heart muscles to also be lowered and render myocardial ischemia. The ischemic cardiac muscles then releases chemicals like adenosine and bradykinin. These chemicals would then stimulate the mechanoreceptors and the chemoreceptors, which then relays the impulse to the sensory ends of the sympathetic and vagal afferent nerves. Angina pectoris would also cause referred pain on somatic organs like the chest, neck, and the mandible. Focusing on the referred pain on the chest, as the upper 5 sympathetic ganglia and the 5 distal thoracic roots of the spinal nerves are actually interconnected by afferent nerves nearby. In other words, they would have the same second-order neuron. When the cardiac sympathetic afferent impulse are being sent to the neocortex through the thalamus in the spinothalamic tract, the brain would then falsely recognize the impulse as that from the chest, rendering referred chest pain. Another referred pain would be felt on the neck and mandible, as the upper cervical spinothalamic tract cells are being stimulated by the vagal afferent fibers. This would cause referred pain on the neck as well as the mandible distal to the neck. Additionally, angina pectoris might also cause complications like nausea and vomiting by stimulating the autonomic nervous system from vagal output.
Thank you, Henry. Then I will talk about different types of angina. First is the stable or typical angina, and its pain is eased by rest after the pain being caused by some physical exertion or some emotional stimulation. And it is caused by chronic stenosing, which means narrowing coronary atherosclerosis, which prevents proper perfusion to the myocardium as the workload of the heart raises. Then the second one is the Prince-Meadows variant angina, and its pain happens at rest and it has no link with physical activity. However, its exact pathophysiology is unknown, but it could be caused by some sudden vasospasm of a coronary trunk caused by coronary atherosclerosis, or it could be caused by some mast cell releasing some humoral vasoconstrictors in the coronary adventitia. And then the last type is the unstable or crescendo angina, and it is the most serious type of angina, and it has more frequent onset of pain, and which lasts for a longer time, and the pain happens frequently at rest, and it could indicate an impending acute myocardial infarction, and it is caused by stenosing coronary atherosclerosis or some complex coronary plaques such as superimposed thrombosis, hemorrhage, rupture, or ulceration. And it could be also caused by some platelet thrombi over atherosclerotic plaque, or some coronary artery vasospasm. Then I'll talk about the functional changes in angina patients. First is the restricted perfusion to heart muscles. Because the atheroma partially blocks the coronary arteries, so the flow of oxygenated blood to the heart muscle is restricted, and it results in some reduced perfusion in these muscles. And the second one is the reduced perfusion to the peripheral tissues, as the inadequate oxygen delivery to heart muscles can lead to some insufficient contraction of these muscles, and it results in some decreased heart pumping. And this can lower the arterial blood pressure, blood volume, and eventually the perfusion to the peripheral tissues. Then I will talk about some compensations in the body in response to angina. As we know that angina is the partial blockage of coronary arteries, resulting in some insufficient oxygen delivery to heart muscles, and it may result in insufficient pumping action and thus some insufficient cardiac output, and that is the heart failure. So to compensate for heart failure, first, there are stronger stimulation of the arterial baroreceptor responses. And also, the heart rate is elevated by increased sympathetic and decreased parasympathetic activation of the heart. To continue, the enhanced plasma levels of the two primary humoral vasoconstrictors, the angiotensin II and the vasopressin, as well as the enhanced sympathetic activation of the systemic arterioles, they may all contribute to an increase in the total peripheral resistance. And then the arterial pressure and the cardiac output rise. So other than the compensation to the heart failure, also the collateral circulation, that is the creation of new blood vessels that can help to provide oxygenated blood to the heart muscle, can also occur to compensate for angina. Lastly, to compensate for angina, the coronary artery vasodilation can also be occurred, and it is the coronary arteries that dilate in order to provide more oxygenated blood to the heart muscles.
The clinical manifestations of angina pectoris include temporary chest discomfort or pain, which may radiate to arms, shoulders, neck, and jaw. Other symptoms of angina pectoris include shortness of breath, fatigue, and dizziness. Next, I will talk about the development of the disease. Firstly, atherosclerosis is initially asymptomatic. The unstable angina develops when the atherosclerotic plaque obstructs the arterial lumen partially. It may further progress to unstable angina, myocardial infarction, and eventually sudden cardiac arrest as a result of the development of atherothrombosis. Let's discuss the complications of myocardial infarction. One of the major early complications is arrhythmia, which is the major cause of sudden death following an acute myocardial infarction. Since the damaged heart muscle disrupts the conduction of electrical signals that control the heart rate and rhythm, it may lead to arrhythmia and cardiac arrest. Late complications of myocardial infarction include the formations of cardiac aneurysm. The necrotic area due to myocardial ischemia heals by fibrosis. This causes the weakness of the ventricular wall and it bulges out due to the pressure within the ventricle, which results in the formation of aneurysms. Moreover, stasis of blood within aneurysm leads to thrombosis and thromboembolism. Cardiac aneurysm also causes the reduced cardiac output, which manifests as congestive heart failure. There are a few ways of treatment of angina pectoris, which include changing the patient's lifestyle, medications, and surgery. The first important step in angina pectoris therapy is to reduce the existing risk factors. This can be achieved by lifestyle modifications, for example, eating a healthy diet, smoking cessation, and exercising regularly. If this is not effective, many drugs are available for the treatment of angina pectoris, such as nitrates, which is used to induce vasodilations and reverse vasospasm, and beta blockers, which is used to decrease the myocardial oxygen demand amount and reduce the risk of arrhythmias. Apart from these, there are some medical procedures to treat angina, such as coronary artery bypass, grafting surgery, angioplasty, and stent placement. These medical procedures are only performed if any positive outcomes is not achieved through prescribed lifestyle changes and proper medications.